Please take it.
Thank you, sir, and a very good evening to all of you, and thank you, NNF and NOEL committee, for the opportunity. So I'll quickly take you through PPHN management, especially from exam point of view. So what is this topic all about? So incidence of PPHN is around 2 per thousand live births, majority term and late preterms, and also in preterms with RDS and BPD, which we are not going to talk today. It is associated with 5 to 10% mortality and also the leading cause of critical illness in NICUs. So let us come to the first question. We all know that fetus lives in a very hypoxic environment and with pulmonary hypertension. So how does a fetus manages to do that? So I have inserted few questions for our students here. So they can put the answers in the chat box. The first question is, what is the normal PaO2 of descending aorta and SpO2 of a fetus? I won't be able to see, sir, if you can see few answers coming here. Anybody? So the normal PaO2 of descending aorta of a fetus is around 25 to 30 mmHg, and the SpO2 of fetus is around 55 to 60%. So despite being so hypoxic, how does the fetus manages to not be hypoxic? So he uses certain characteristics, like first one is tolerable hypoxemia with very high blood flow. The cardiac output of an adult is 150 ml per kg per minute, whereas a fetus has a cardiac output of nearly 450 ml per kg per minute. So this helps in tolerate this hypoxemia. Second point is minimizing the cardiac stress. It bypasses the high resistance pulmonary circulation through PDA and offloads RV through patent ductus arteriosus. Also, the fetus focuses on preductal SpO2, mainly focusing and providing higher oxygen saturations to brain and heart. And there is lower and tolerated oxygen level in the postductal organs. And this is mainly achieved with the help of high cardiac output. Apart from this, a fetus has high fetal hemoglobin and higher hemoglobin concentration as well. So all these properties help fetus survive this hypoxic environment in the utero, and these are the characteristics we can utilize for managing PPHN as well. So another question for our students, list the factors that determine oxygen delivery to the tissues in order of importance. First is dissolved oxygen, hemoglobin concentration, hemoglobin saturation, or cardiac output. So this is the fastest finger first. What is the order of importance here? Any answers there, sir? Am I audible clearly?
I can't see actually. You are audible, but
okay, sir.
Go ahead.
The answer to this is DBCA. It's cardiac output followed by hemoglobin concentration, hemoglobin saturation, and then the dissolved oxygen. So what happens immediately after birth? We all are aware of that there is a dramatic increase in pulmonary blood flow as soon as the baby takes his first breath. Simultaneously, there is a significant fall in pulmonary arterial pressure and a rise in systemic arterial pressure because of the clamping of the umbilical cord. So with this normal adaptation, if there is something which goes wrong or there is already something underlying that the fetus or the newborn fails to adapt and leads to pulmonary hypertension. So let us look into the etiology of pulmonary hypertension. We can divide it as underdevelopment, where the parenchyma as well as the vasculature is underdeveloped. We commonly see this in diaphragmatic hernia, pulmonary hypoplasia because of various causes, mainly renal agenesis. Even early onset leaking, oligo, and early onset IUGRs do have this. CPAM. Maldevelopment, mainly because of maternal drugs. Maldevelopment means there is excessive vascular remodeling with muscular layer, leading to failure to adapt to the postnatal changes. Maternal drugs like antidepressant drugs like SSRIs and NSAIDs, obstructive cardiac lesions, and maladaptation, which is mainly the most common reason of PPHN we see in our clinical practice: hypoxia, asphyxia, birth asphyxia, acidosis, and sepsis. There are various other reasons as well. There are nearly 10% of PPHN are idiopathic, and the causes for secondary PPHN can be divided as acquired or congenital. In acquired, we have meconium aspiration syndrome, mnemonic is master, asphyxia, sepsis, TTNB, effusions, and RDS. In congenital, it can be remembered as drastic, diaphragmatic hernia, respiratory anomalies, alveolar capillary dysplasias, protein deficiencies, and many more disorders. So coming to the diagnosis of PPHN, when you are on duty, when you are taking rounds and you have a child with respiratory distress, how do you identify that he additionally has PPHN or PPHN is the primary pathology there? So first important clue comes from the history, where you will get a history of abnormal scans. You have an antenatally detected CDH. You get the history of maternal drugs. You get the history of birth asphyxia or sepsis. Also, when you examine the child, you have pre and post-ductal saturation difference of more than 5 to 10% and PaO2 difference of 10 to 20 mmHg in pre-ductal and post-ductal. Labile hypoxemia, which means that child is comfortable at one point of time and is desaturating when he's crying or being disturbed. We will look at chest X-rays, which will help us in delineating the underlying cause. Hyperoxia hyperventilation test was done previously in past, and we are not doing it at present. And the gold standard now in diagnosing PPHN is echocardiography. So these two, pre-ductal, post-ductal saturation difference, especially if the shunting is happening through ductal arteriosus, ductus will be present. And labile hypoxemia are mostly classical of PPHN, and you should be able to pick this up during your rounds. So these are the various X-ray patterns which are seen in secondary PPHN. X-ray helps you give the clue whether it is parenchymal disease underlying, or it is a congenital malformation, or it is a black lung PPHN, or also called as idiopathic PPHN. So these are the various conditions which can lead to PPHN in babies. Like TTNB, you can see fluffy, hyperinflated shadows, asymmetric shadows in meconium aspiration. Congenital anomalies like CDH or CPAM, pneumonia, effusions, and air leak syndromes. Coming to the gold standard, that is 2D echo. So 2D echo you will be using for two main purposes. First, to rule out any structural cardiac disease, underlying structural cardiac disease. Secondly, to assess the severity of pulmonary hypertension and to assess the shunting which is happening at which level. So you have an eyeballing, you rule out the structural disease, then you do an eyeballing whether the septum, what is the position of the interventricular septum. And there are various parameters which are there in detail, which is not in the scope of this particular talk today. So echo can help you find out the severity of PPH and also the response. Coming to goals of therapy, we have I won't say PPHN is just managing with pulmonary vasodilators or IN or sildenafil. It is much more about the supportive therapy, care of the lung parenchyma, the cardiac system, and lastly the pulmonary vasculature. Let us see each one of them one by one. Coming to supportive management, the most important thing is thermoregulation. Hypothermia alone has been shown to increase or worsen pulmonary hypertension. So child should be euthermic, avoiding hypothermia and hypothermia. Electrolytes and glucose should be in normal range, including the hemoglobin in the normal range, avoiding polycythemia as well as anemia. This is one group of disease where we allow sedation and analgesia because if the child is agitated, it will lead to catecholamine release and increase your pulmonary vascular resistance. So adequate sedation and analgesia is equally important. And lastly, nutrition. Adequate nutrition is definitely important for every newborn disease. Coming to lung parenchyma, we start with oxygenation. So as soon as the child is born, oxygenation starts in delivery room. And there are various studies showing that resuscitation with 21% oxygen versus 100% oxygen, what is the response? We all know we are resuscitating term and late preterms with 21% oxygen in as per NRP. And the reason being that the study has shown that if you are resuscitating with 21% oxygen, as shown by the green bars here, versus 100% oxygen, as shown by the red bars here, and you assess the response to pulmonary vasodilators 90 minutes later. So you can see the green bars, the 21% was extremely beneficial as compared to the 100% oxygen saturation done in delivery rooms. So to summarize this particular slide, initiation of resuscitation with room air gives you a better response to pulmonary vasodilators later in NICU. Higher exposure to oxygen leads to poor response to pulmonary vasodilators, and this is all because we all have endogenous nitric oxide. And when we give 100% oxygen, we are converting them to superoxide radicals and damaging the inherent or endogenous nitric oxide, converting into peroxynitrites, also damaging the cyclic guanylate cyclase pathway, which I'll be discussing later on. So the point here is resuscitation with 21% oxygen right from the delivery room. What are the factors that predict PPHN following asphyxia? Severe birth asphyxia, need for chest compression is a predictor of severe PPHN in ICU. Predisposing parenchymal lung disease like meconium, aspiration, or pneumonia are risk factors for severe PPHN. Need for more than 50% oxygen in immediate postnatal period and anemia for any reason because of cord accident or placental accidents. This can lead to, these are the predictors of PPHN in ICU. So another concept of oxygenation, this is a question for our audience again. A 37 weeks male weighing 3.3 kg was delivered by emergency LSCS and was admitted at birth for respiratory distress. He had mild respiratory distress, so he was put on oxygen by hood for a few hours. After a few hours, his distress had worsened with FiO2 requirement of 95% to maintain his pre-ductal saturations of 90%. So what do you think? What is the likely diagnosis now? And what is the underlying mechanism for this particular condition now? Just waiting for one or two answers here. Any cases that the child had mild respiratory distress at birth? Someone has raised hand. You can unmute and say. Yes, someone has said correctly. Absorption atelectasis, correct. So this is the concept of absorption atelectasis. What happened is when any baby with respiratory distress, we put the child on 100% oxygen. What we do is that oxygen is a very diffusible gas. And if you fill the alveoli with oxygen, it will diffuse through alveoli and lead to atelectasis of those alveoli, leading to VQ mismatch, shunting, and leading to hypoxic respiratory failure. So you're converting a simple TTNB to a malignant TTNB, which should be avoided. This absorption atelectasis should be avoided. Any child who is having retractions or grunting does not need oxygen. He needs pressures to open up his alveoli and maintain FRC. Now coming to another point of oxygenation is choosing appropriate targets for optimal oxygenation. What should be the ideal site for choosing your monitoring SpO2s? It should be pre-ductal, and I'll be talking about the other cutoffs. So as you can see here, as you can see here, at the SpO2 of 93 to 97%, your PVR is lowest. And but slightly higher FiO2s are required for that. But at 90 to 94, PVR is high, but FiO2 is low. So ideally, we should be managing these babies in the range of 93 to 97% as an ideal target. And if you see at the higher targets as well, your PVR, which is shown in the orange color, is going up again. So hyperoxia is again increasing your PVR as by the mechanism we have discussed just now. And the lower saturations again causing hypoxia and leading to increased PVR. So you have to maintain a tight oxygen saturation in these babies, though slightly higher than what we say for preterm babies. Now, how do you monitor oxygenation in a PPHN baby? So we have two indices. Oxygenation index we all are aware of. So oxygenation index is mapped into FiO2 into 100 by PaO2. So previously it was said that an OI of more than 25 is an indication of inhaled nitric oxide, but these days the cutoff has gone down to as low as 15. People are now even considering INO at an OI of 15. So for OI, you need an arterial prick or an arterial line in C2. So another non-invasive method of OI is oxygen saturation index, where you replace PaO2 by SpO2. So you can continuously monitor this, and this is nearly half of your OI. The correlation between them is this. That is, OSI is nearly 50% of oxygen OI. Another parameters are there like ADO2, A by A ratio, which are not ADO2 we use commonly, but A by A ratio and PF are not commonly used in neonates. Coming to mechanical ventilation of our lung parenchyma, we all know there is no set rule, but what we want is to ventilate the lung at FRC, avoiding very high volumes and low lung volumes. We all know about this particular graph that FRC and PVR follow a U-shaped curve where at a particular FRC, the PVR is lowest. If your FRC is high because of overdistension, you're going to have an increased pulmonary vascular resistance because you'll be compressing the arteries or capillaries nearby. And on the other hand, if your FRC is low, again your PVR is going to go up because those alveoli collapse and the body will try to constrict the arteries or capillaries. So we need an optimal FRC. How do you decide clinically whether you are ventilating at FRC or how much do you need? So history and X-rays are definitely going to help you. If you look at these particular X-rays, so suppose you are dealing with a secondary PPHN due to parenchymal lung disease or loss of alveolar space, consider early surfactant therapy and higher MAPs to ventilate this lung, to recruit the lung and ventilate this particular baby, followed by pulmonary vasodilators and your target SpO2s and ABC targets. If you have a black lung or idiopathic PPHN or a hypoplastic lung because of various reasons, we follow lung protective strategy, avoiding expansion and providing FRC. So this will be the technique of ventilation. Again, as I said, there are no set rules. What should be the initial settings? But if you are ventilating on pressure control mode, slightly higher peaks, 25 to 28, with slightly higher PEEP as well, up to 6 to 7, are generally required. FiO2 based on your SpO2s. If you are ventilating on HFOV, starting with a MAP of 12 to 14 or 2 more than the conventional ventilation with a frequency of 8 to 10 and amplitude of 20 to 24. The main concept is the main idea of ventilation these days is we are done with those hyperventilation and alkalosis and other things. What we follow these days is gentle ventilation, that is tolerable hypoxemia with a PaO2 in the range of 50 to 80 mmHg and pre-ductal saturation, as I said, 93 to 97%. We also allow permissive hypercapnia while maintaining our pH of more than 7.25. Very, very important. If your pH is falling less than 7.2, you have to treat hypercapnia, but if it is remaining within 7.25, above 7.25, we can continue this permissive hypercapnia and we avoid respiratory alkalosis. So next question, all the following statements regarding effect of pH, PaO2 and PaCO2 in pulmonary and cerebral circulation are true, except hypoxia causes pulmonary vasoconstriction and cerebral vasodilation. Acute metabolic acidosis dilates the cerebral circulation. Acute respiratory acidosis increases PVR and dilates the cerebral circulation. Marked increase in pressures reduces cardiac output and cerebral blood flow. Just 30 seconds for your answer. Somebody has said A, somebody has said C. So B. So right, the correct answer is B. See, hypoxia works different in pulmonary and different in cerebral circulation. If there is hypoxia, there will be pulmonary vasoconstriction, that is correct, and it will lead to cerebral vasodilatation. Metabolic acidosis does not have any effect on cerebral circulation because H plus ion do not cross blood-brain barrier. Acute respiratory acidosis, again, acidosis will cause increase in PVR, and we all know hypercapnia causes cerebral vasodilatation. C is correct. And marked increase in MAP will lead to decreased cardiac output by compressing your pulmonary vessels and decreased cerebral blood flow as well. So A, C, and D are correct, and the right answer except is B. So coming to role of surfactant therapy when the lung parenchyma is involved. So consider this as a diseased lung with a non-homogeneous disease. You see here one disease alveoli which is collapsed and one alveoli which is open but over distended. So what happens is by Laplace's law, the remaining gas from this collapsed alveoli is going to move to the open alveoli, further over distending it and compressing the capillaries nearby. And the capillaries associated with the collapsed alveoli are also going to constrict. In this scenario, if you are going to use pulmonary vasodilator, especially INO, this is not going to work because this is not going to reach the place where it is supposed to work. If you give surfactant and recruit the lung well, early surfactant and recruit the lung well, this is what you are going to achieve. Well open lung, uniform distribution of INO, and a good response with improved PaO2 and decreased pulmonary vascular resistance. So when should you consider surfactant therapy in managing PPHN? The indications are PPHN secondary to parenchymal lung disease. Oxygenation index more than 5 is an indication for surfactant with parenchymal lung disease. Need for more than 40% oxygen to maintain preductal SpO2 of more than 90%. However, caution has been set in idiopathic PPHN where you have black lung PPHN, your X-rays are showing typically black lung. And also in diaphragmatic hernia, it has not shown much benefit. So this was one RCT which showed that INO alone versus INO plus surfactant, the death rate and the ECMO rate was significantly lower in INO plus surfactant group. So this was about supportive therapy and lung parenchyma. Coming to pulmonary vasodilator therapy. So we have three pathways in pulmonary vasculature: nitric oxide pathway, prostacyclin pathway, and endothelin pathway. Now let us just imagine this is an endothelial cell and this is a smooth muscle cell. So we all produce nitric oxide. So we have our endothelial nitric oxide synthetase, which produces nitric oxide. Nitric oxide then diffuses to smooth muscle cell, activates cyclic guanylyl cyclase, produces cyclic GMP. Cyclic GMP goes and blocks the calcium channels leading to pulmonary vasodilation. Similarly, this cyclic GMP is broken down to GMP by phosphodiesterase 5 enzyme. In arachidonic acid and prostaglandin mediated pathways, again, the main mediator is your adenyl cyclase, which produces cyclic AMP. Cyclic AMP blocks calcium channel and hence dilates smooth muscles. And it is broken down by phosphodiesterase 3A enzyme to AMP. Now, this is the crux for using our medications. First is your INO, which is the drug of choice. We also have endothelin receptors. Endothelin A is a strong vasoconstrictor. So, another second drug is sildenafil, which blocks your phosphodiesterase 5, hence increasing the levels of cyclic GMP, and it acts in synergy with inhaled nitric oxide. Phosphodiesterase 3A is blocked by milrinone, and it acts through cyclic AMP pathway. We also have prostacyclin or alpostadil in selected situations where they can help when the ductus closure is there and there is no other shunt present. Alpostadil, and the last drug is bosentan, which is available as oral drug, but not much evidence is available currently on bosentan, but it acts on endothelin A pathway and causes smooth muscle dilatation or pulmonary vasodilatation. So these are the common drugs we are using currently for management of pulmonary hypertension in neonates. So as I said, the drug of choice is inhaled nitric oxide. So, but the rule for starting inhaled nitrous oxide is that the lungs should be well recruited. If it is a parenchymal lung disease, you should give surfactant first at an OI of 5 and then consider giving INO as we had seen in the previous slides. So the rule for starting INO is 20-20-20 with at an OI of 20, may consider at an OI of 15, starting at the dose of 20 ppm and increase in PO2 by more than 20 mmHg. Weaning is started as 60-60-60 or some people do as 30-60-90 rule that within 60 minutes of starting INO, you have a decrease in the need for oxygen FiO2 less than 60% and your PO2 is more than 60 mmHg or your SpO2 is more than 90%. So this is the drug of choice because it is a selective pulmonary vasodilator but is contraindicated in LV dysfunction and methemoglobinemia. If your echo is showing a sign of LV dysfunction, consider milrinone as a first-line pulmonary vasodilator rather than giving iron. And this inhaled nitric oxide goes to the blood and gets converted into methemoglobinemia, so it is not considered in methemoglobinemia, and we have to monitor methemoglobin levels. Lastly, coming to the cardiac system, so what is the pathophysiology happening here? This is a vicious cycle of pulmonary vascular resistance and cardiac output. So what we have primarily is increased peripheral pulmonary vascular resistance, which leads to RV systolic and diastolic dysfunction, decreasing RV output and also RV filling, which leads to you also have shunting through PDA or PFO, which is right to left shunting because your pulmonary resistance is high. This leads to decreased pulmonary blood flow. And then you have decreased LV because of decreased pulmonary blood flow, LV preload. And this leads to hypoxemia, acidosis, VQ mismatch. Finally, this all leads to LV dysfunction and systemic hypoperfusion and shock. So you need to break this vicious cycle when you're managing a child of PPHN. But as I said, it is not only about pulmonary vasodilators. All these things you need to keep in mind that they are interrelated. So RV dysfunction can be because of various reasons. It can be because of low RV load, because of hypovolemia, arrhythmia, high MAP if you are giving, or vasodilatory shock. It can be impaired RV contractility because of ischemia, cytokine-induced, or impaired LV function, cardiomyopathy, or there is already a high afterload because of increased pulmonary vascular resistance. So if there is a low RV load, you need to optimize this RV load with cautious bolus. If you see more than 9 ribs or 8 ribs in X-ray, wean your map because you are over distending the alveoli and decreasing the RV preload, and consider vasopressors. If there is an impaired RV contractility, you need to augment RV systolic function by dobutamine or milrinone, and if epinephrine, if it is sepsis or hypertensive, and reduce RV afterload by using pulmonary vasodilators, as we had already discussed. Apart from RV, you need to support LV as well. You might have to use inotrope for ventricular dysfunction. And the goal is to improve systemic blood pressure and avoid systemic hypotension, but not to supraphysiological pressures. You don't have to chase the numbers for BP, but your goal should be to improve perfusion, which you can monitor by monitoring CFT, your lactate levels, and your urine output. So rather than chasing numbers of BP, you need to keep the perfusion of the tissues well. What are the etiologies for systemic hypotension in cases of PPHN? It can be reduced left ventricular afterload because of sepsis, hypoxia, or the drugs we are using like milrinone and sildenafil do cause systemic hypotension as well, apart from causing pulmonary vasodilation. Reduced ventricular preload because of low pulmonary venous return, blood loss, or dehydration, or in rare cases, septal deviation to the left. Pump failure because of the underlying pathophysiology like hypoxemia, asphyxia, acidosis, or there may be an underlying structural heart disease which we need to rule out. So these are the various vasopressors in smooth muscles and endothelial cells. We have alpha-1, alpha-2, beta-1, beta-2, and the vasopressin receptors. So norepinephrine acts on alpha-1 and alpha-2 receptors, and dopamine acts as a precursor for this. Dopamine acts through dopamine receptors and also through by getting converted into norepinephrine. Epinephrine acts on beta 1, beta 2 receptors, all of us know that, and vasopressin acts to vasopressin receptors. So, what all these drugs do is increase the smooth muscle calcium, thereby causing vasoconstriction. Norepinephrine also leads to, through alpha 2 receptors, it has mild vasodilatory effect in pulmonary system at the lower doses, not in the higher doses. And vasopressin through V1R receptor also causes pulmonary vasodilation and while causing systemic vasoconstriction. So vasopressin is coming up these days as a drug of choice for managing hypertension in PPHN because you see it is causing pulmonary vasodilation and systemic constriction, which that is the exact effect we want when we are managing hypertension in PPHN. Slightly busy slides, sorry, but these are dopamine. The receptors are dopamine, beta 1 and alpha 1 receptors, epinephrine, beta 2, alpha 1 receptors, and beta 1 receptors, and norepinephrine. Then you have milrinone, levosimendan, and vasopressin. And as I had already discussed, that what are the mechanism of these antidotes. This is just a slide about the newer pulmonary vasodilators, which are in pipeline or the experimental work is being done in various aspects of managing PPH and more selective drugs so that we have less side effects. Coming to this is the summary of acute therapy in PPHN, which we have discussed recently now. So, right from monitoring T ductal saturation, early surfactant, minimal stimulation with sedation and analgesia, managing parenchymal lung disease, conventional ventilator settings, as I have already discussed, managing BP and tissue perfusion, and considering INO when you're having evidence of PPHN with high OIs. So this is another flow chart. Optimize ventilation, lung inflation, sedation, acid base, treat sepsis, check BP, pre and post ductal oxygen. If your MAP is low, mean BP is low, consider a cautious fluid bolus, 10 ml per kg. Consider starting dopamine, but these days we are not considering dopamine because dopamine also leads to pulmonary vasoconstriction and might worsen pulmonary hypertension. Add epinephrine 0.04 to 0.4 mics or norepinephrine. May consider hydrocot, and if echocardiographic assessment you have in closing duct with RV dysfunction, consider giving prostaglandin. If not, then consider milrinone and dobutamine as well. So take-home message is avoid hypoxia and hyperoxia while managing PPHN starting right from the delivery room. Supportive care is the key and equally important, especially avoiding hypothermias and keeping your hemoglobin and in the normal range. Use gentle ventilation strategies. Get used to functional echoes for detecting and monitoring PPHN. Consider early the surfactant. INO is the drug of choice and cardiac centric approach. Thank you.
Thank you, Dr. Jain. Excellent discussion, excellent elucidation, and very wide and knowledgeable things for our all participants. So I'd like to stress upon few things which has already been discussed by Dr. Janisa, that so far as etiology is concerned, we have to consider that whether it is primary or secondary PPHN, and in the pathophysiology, I'd like to stress upon a point that ultimately it's the intrauterine remodeling of the arterioles, of the pulmonary arterioles to be specific. That gives rise to the PPHN, which is the real PPHN. And the other kinds of PPHN, the dynamic PPHN, that can happen due to various conditions in the NICU, be it asphyxia, acidosis, or even a RDS in which there is an intrapulmonary shunting. And then coming to the next sitting of diagnosis, in the diagnosis, role of echocardiography is very important. We have to document a structurally normal heart in order to reach a PPHN, which is the real PPHN, and not underlining the factors that in the management, the basics remain that supportive care is very much important, avoiding hypothermia or hyperthermia and maintaining a normal blood pressure, or the basic bottom line is the persistent pulmonary hypertension. The very word says pulmonary hypertension. So we have to keep the systemic blood pressure above the pulmonary pressures. So that underscores the importance of maintaining a blood pressure, the systemic blood pressure, so to say, which is above the pulmonary blood pressure, so that the shunting reduces, the intrapulmonary, the extrapulmonary shunting reduces, and the PPHN improves. And again, the previous things of hyperoxia, doing hyperoxia can cause more damage. So you have to go into a normoxia, and the gentle ventilation strategies, avoiding hyperventilation as advocated previously, that has to be taken into account also. So and early surfactant has got a great role that in remodeling, the opening of the lungs and acting, the opening of the lungs for the INO and other things to act. So early surfactant is very important, and nevertheless the role of sildenafil is also very important. So these are the various things. So if there is any questions, we can discuss. Dr. Jain, can you see the questions? I can't see actually.
Yes, sir. There is
Okay, so there is one
uh,
preferred drug of choice in hypertension with cardiac dysfunction. Dr. Sarwan has asked.
preferred drug as such with cardiac dysfunction. If you are having like LV dysfunction, consider milrinone.
Right.
And yeah, and then you can consider norepinephrine. And the best is nowadays is vasopressin because it is no effect on cardiac muscle, but it is causing systemic vasoconstriction and pulmonary vasodilatation.
Correct. So depending on your echo findings, you can decide upon that. And so Dr. Sahil has asked how to taper inotropes when the PPHN is improving.
You will have clinical clues for that, especially if your last one goes first. So if you have a better tissue perfusion, like your CFTs are normal, your heart rate is in the normal range, lactate is normal, urine output is good, you start tapering inotrope, and the last one you also monitor BP. So the last one goes first.
Okay, nice. So the last one goes first. By that way, you taper. So Dr. Rishi has asked, is there any contraindication of INO in preterms?
Yes, I just answered. No, there is no contraindication of INO in preterms. In fact, people are now working with INO in preterms, especially in BPD cases. It can be used in premature babies.
Right. So in premature babies, I would just add that in RDS, though it is PPHN is told to be classical disease of term and post-term babies, in many times in RDS, the intrapulmonary shunting gives rise to the PPHN component. That is in preterm babies as well. And INO has been tried for RDS also in some situations. So Dr. Dorothy Batra has asked, 100% FiO2 during ventilation, does it help?
Definitely not, because if you're needing 100% FiO2, please look at, as we have discussed, lung parenchyma. Why is he requiring 100% FiO2? Either idiopathic, but definitely try to wean off with various modalities like early surfactant if you have an X-ray showing parenchymal changes, or and then INO, because ventilating at 100% is not going to give you the outcome. You need to look for the underlying cause why your child is requiring 100%, and you can help him with surfactant, especially early surfactant and good map. Also consider like if you have tissue perfusion map, take care of hypoxia and acidosis because these lead to a vicious cycle of pulmonary hypertension. So ventilating at 100% FiO2 is not a good idea.
Very right. So the previous thing that give hyperoxia and give 100% oxygen, and it does not harm a term baby because there is no risk of ROP and other issues of hyperoxia is no more stands. And as Dr. Jain told very correctly that if you are giving 100% oxygen, then why it is necessary? We have to find out the cause. So gentle ventilation And optimal ventilation is more important than giving a very high FIO to like 100%. So the next question is, will melanin cause hypotension?
Yes, definitely milrinone causes hypotension because it is an inodilator, right? It does cause systemic hypotension, and also renal injury you have to be careful about when you are using milrinone.
Right. So melanin, you have to be careful while using it. Any role of magnesium sulfate?
I'm not aware of this particular thing. I've not used. Yeah, previously we had read that it does help, but currently there are no guidelines. Maybe you can add to this, sir.
No, there is no current recommendation of use of magnesium sulfate per se in PPHN. You have already told about the other drugs like bosentan and all, which are and the other ones which are in trial like tadalafil and prostacyclin rarely is used, and so they can be, but not magnesium sulfate is not currently recommended. Each echo diagnosis is compulsory before starting INO for PPHN.
Ideally, yes.
Yeah, right. Right. Ideally, you should have a echo to say that heart is structurally normal. If you go back to the basics of definition of PPHN, that one of the criteria is a structurally normal heart. So,
Yes.
so that you have to stick to the basics, I would say.
Also, you need to rule out LV dysfunction because if you use INO in LV dysfunction, your child is going to worsen.
Right. Correct. Okay, so I don't see any more questions. So it was a wonderful discussion of pathophysiology and management of PPHN. So thank you, Dr. Jain. If there is nothing else, we can close the session.
Yes. Thank you so much, sir. Thank you all of you.
Thank you, all the participants. Thank you for the session.
Thank you, sir.
Yeah, thank you.